Okay, so thank you to our Chinese faculty, our Far Eastern faculty, for staying up later than expected, to answer a few questions. And our first question is to Dr. Chen Yongshen from I think from the chat. What is the typical length of stay in hospital for your cohort of patients or for Asian patients in general?
We haven't consolidated our data, but anecdotally, we do have a few patients who stay for a couple of months, and that's really because we haven't quite sorted out the aftercare in the community. I'm sure as we sort those things out, the length of stay will decrease. Yeah.
Okay, there's a second question directed to you. What is your post-operative weight-bearing status upon discharge?
So I follow what Professor Hua does, and that is a protected weight bearing post-operative, provided the patient does not have a plantar ulcer.
Fast, brilliant.
Mm.
Okay, so hopefully one of the Chinese speakers will be able to translate the questions to Dr. Hua.
Yeah,
Um,
I'll do
so
that for you.
this question is to Dr. Hua. Uh,
Yeah,
could there be a potential use case or indication for painful diabetic retinopathy, even in patients without wounds?
花老师，这个是那个视网膜的那个问题啊，他们是
嗯，
问您那个视网膜的那个病变，如果用那个 TDT 有效吗
是这样的，对于视网膜
？I'll
的病
translate
变
that.
TTG 并没有非常明确的疗效，因为我的病人有一些糖尿病足的病人也合并有视网膜病变，我跟我的眼科同事观察过这些病
Short
人，
answer is no.
并没有明确的
Okay.
证据能有
嗯。
视网膜病变的改善。
So anecdotally, he does have some patients with a retinopathy. However, in a follow-up in conjunction with the ophthalmologist, he did not see any objective evidence of improvement in retinopathy in patients who have undergone TDT. So short answer
Okay.
is no. Mm.
Okay, the second question to Dr. Hua. Has this been tried in patients with vascular claudication syndrome without ulcers
这个
or
是那
without
个
any
间接
dried
性
gangrene?
波形的那个问题。
嗯。是这样的啊，就是我们还是这个只是使用在这个有这个创面或者坏疽或者感染的糖尿病足的病人。关于这个缺血病而没有这个组织缺损的话，我个人认为已经有成熟的药物和治疗方案去改善这种血管
There
就是缺血的问题，而不需要用这个再生的技术来进行治疗。这
好，我
存在
帮您翻。
于一个过度医疗的问题。嗯
好，我帮您翻译一下。So,
嗯。
he thinks that there are already established methods, conventional methods for treating vascular claudication in the absence of any tissue loss. This being primarily a tissue restoration technique, should not be used in the treatment of vascular claudication.
Okay. Right. There's another question. The concept of antibiotic cement on application on a skin defect. How does this work and how long to keep this antibiotic cement on? And will this regenerate skin or form granulation tissue?
That's a question for Professor Hua.
I think so. It's under that list I've been given.
OK，花老师，这个问题是问您那个
抗生素水泥是吧？
抗生骨水泥对，您是怎么样用，还有用多久？
是这样的，抗生素骨水泥是我们从这个治疗骨血炎里头借鉴出来的。它的治
是
疗
treatment
原
for
理就是
paracetamol itis。
局部的应用这个抗生素骨水泥，可以通过释放抗生素达
local
到
and
一个抗菌的作用，从而有利
local
于这一
elution
个
of antibiotics。
后面组织的这一个就是健康化。一般来说的话，
treat the
我们是
infection and
用
turn the tissues healthy。
1到2周的时间
He
啊。
uses it for about 1 to 2 weeks
Okay.
each time. Mm.
Okay.
So that's a topical application, and it works on local elution of antibiotics, and usually he applies it for 1 to 2 weeks at most, and he removes it. And that's
So,
for PMMA cement. It's not talking about the resorbable ones. Yeah.
okay. All right.
Mm.
I have a question in from the chat to Dr. Theodolu.
Same
Um,
out.
Thank you very much, for translating. So, Dr. Theodolu, what is the benefit of an adjunctive ring over monolateral fixator?
Yeah, I think I presented that our reasons for it. We consider every one of these, we do a potential iatrogenic tibial fracture in the diabetic population. We already see the concerns we have with sarconeurogenic arthropathy. Diabetic bone is different than non-diabetic bone. So we've shown with our studies that the ring fixator provides increased stability on this corticotomized bone. And so we rely on that. We practice in the US. It's a little bit potentially different from a medical legal standpoint to get these, we've had insufficiency fractures of the tibia in performance of this, and the ring protects that. Secondly, it does allow for extension from the ring down to the foot ring to a foot ring to do offloading purposes and treatment down distally as well.
Thank you very much. That's very clear. I have a question for Dr. Mills. If we were to do a study of the results of TTT on my cohort of patients, would it make more sense to report their Wi-Fi stage instead of Wagner?
Yeah, I think I sort of answered that in the chat. So at least I know a lot of orthopedists still use Wagner, but from a vascular surgery standpoint, it's not very helpful because there's no measurement at all of ischemia. And if you take, for example, gangrene, you can get gangrene from large vessel occlusive disease. You can get it from infection where the vessels thrombose. So that it's true that gangrene does worse, but from a vascular surgery standpoint, I want to know, did the gangrene happen because the foot got infected and this needs to be drained, or did it happen because it's ischemic? In which case, if it's dry, you don't want to drain it first, right? So, I think Wi-Fi is more complete.
And I have to say, from even in my work, and I mentioned this in the chat, Dr. Mills, that Wi-Fi, we agree with that wholeheartedly, and Wi-Fi is absolutely critical, particularly if you're working closely with your vascular surgeons when you're doing these procedures. We fully agree with that.
Yeah. Sorry to interject, Alex, just in case you didn't see it. There was one more question asking, has anyone had any experience with deep venous arterialization or alone? I think that question is directed to Dr. Miller.
Yeah, I put it in the chat. We have a reference from our center. So we started doing it with Dr. Montero Baker when he was with us. Before there was a commercially available device. So most of us use it only when we've exhausted all other options, so that the patient doesn't have a target that you can reach with angioplasty or with bypass. And we've gotten pretty good results in those patients. And I look at it kind of like what I think TTT is. It's an indirect revascularization. So when I look at some of the images of TTT, you get collateral vessels that develop in response to it, but that takes time. DVA also takes time. It seems like you don't get improvement in perfusion for 6 weeks to 3 months. So we try not to do a lot of debriding during that time. I think there's some parallels in how they work. So DVA, for those that aren't familiar, basically it directs blood flow into the deep venous system of the foot. And if you look at some of their angiograms over time, they develop these microvessels that look like neovascularization, and they persist even after the DVA fails. It's pretty interesting.
And I agree with that too, Dr. Mills, Dr. T again. Well, interestingly, I have never seen a more robust regenerative response than I have seen doing distraction angiogenesis. In fact, we've got studies and we show this response within 2 weeks. It's a dramatic, almost exaggerated angiogenic effect that we've seen. And I don't know if my Chinese orthopedic colleagues can speak to that as well, but we see a pretty acute response to this with regards to vascularity of our wounds and upon initiation of that corticotomy and its performance.
And how are you assessing that?
We do
Vascularity
clinical exam, clinical bleeding and non-bleeding wounds grossly. Two, we do thermography, FLIR examination, and we see thermal changes that take place. There are truly, and then TCPO2s can be considered locally in that area as well. There are really no wonderful validated studies that's what we should be focusing on
To come to this
really
meeting?
to see that, so to speak. So, but we use a fair amount of FLIR thermography to show the temperature gradient changes, and it's amazingly robust. And we've also done a pretty acute subsequent catheter angiograms with these patients and see this blush that takes place that didn't exist pre-corticotomy. And then with the and when we do these angiocasts, one of the benefits in my institution is I have two vascular surgeons, and the technique and the size of catheter that's utilized remains constant. So we can't see that potentially as a bias to what we're looking at.
All right. What a blast. Thank you, everybody. I apologize that I have to start to wrapping up our conference. And before we wrapping up again, let's thank our sponsors for this year, the first term of our Mount Rushmore Charcot for the Reconstruction Forum. The success is really dependent on all our distinguished guests. Your support, I really sincerely, we thank your presence here and to give us such a wonderful talks. And our gold sponsor, Orthofix, silver sponsor, Vilex, Fusion Orthopedic, Blue Ocean Global, and Paragon 28, and our bronze sponsors, Lee Medical, Line Medical, Restore 3D, Bojane, Synaptic, Induce, and Unite, Hoosier Osteotronics, and the BFX. And thank you so much. So absolutely, this is a treat for the surgeons alike, like us, orthopedic, podiatrists, vascular surgeons, and we will incorporate mid-level providers in the future with this very difficult, which requires a multidisciplinary, a team work to offer this ever-increasing, we can call it a pandemic, or some areas endemic and pandemic difficult patients, to provide them a solution. So here I would like to express my sincere thanks to all our guest speakers and sponsors one more time. And we are playing live, and we recorded session will be live on YouTube, and we send it out the links to all registry, all surgeons who registered. So wait and tuned for our further communications on our recordings. And I would like to tell us our planning for next year. We'd like to go live in Midwest United States and welcome you all. And thank you very much. And if there's any questions, Alex, do you have any questions, any wrap-up comments?
No, I'd just like to congratulate you on organizing this fantastic forum and bringing basically an international panel of experts together to try and solve and answer some of these difficult questions that we all face as clinicians. So well done, Alan. Thank you.
All right. Thank you very much. Also, thanks our technical teams. And due to the difficulties of connections from overseas, we have a technical teams in Shanghai, and also we have our technical team here. And Joe and Mason did a fantastic job. And without them, I do not know how this is going to be possible. Thank you all.